In this discussion, we are going to discuss B cell disorders. B cell disorder consists of Bruton X-linked A gamma globulinemia, then selective IgA deficiency, and then common variable immunodeficiency. So first of all, we have this Bruton X-linked A gamma globulinemia. So B for Bruton, so it's X-linked, so it is increase in males. So the hereditary pattern is from father to son and then to the grandson. So it is very much common in boys. And pathophysiology include it is the defect in the B cell tyrosine kinase receptor is defective, which leads to defective maturation of B cell, maturation defect. As we know that B cells are produced in the bone marrow and mature or proliferate in the spleen. So a spleen, lymph nodes. So in our lymph node biopsy, we have scanty, hypoplastic or absent primary follicle or germinal center. Then this is A gamma globulinemia, A gamma globulinemia. So it means it can decreases all kinds of immunoglobulins. Why? Because there is no B cell maturation, so there is no class switching. If there is no class switching, then the IgM, IgE, IgG, they cannot be transcribed. So so the presentation, this is the pathophysiology. The presentation is always for the B cell disorder, there is a mnemonic: please shine my skis. So there is infection, recurrent infection of Pseudomonas, Strep pneumo, Haemophilus influenza, Neisseria, E. coli, Strep Klebsiella, Group B, Streptococcus. So there is so these bacterial infections. Its presentation, it has a bacterial infection. Also there is increased giardiasis rate. Why? Because there is no IgA. As we know, no immunoglobulin, no IgA, no protection in the GIT. And also it is present post 6 months when the mother immunoglobulin or immunity from the mother wanes off. So this is all about Bruton X-linked A gamma globulinemia. Next we have in this B cell disorder, we have always intact T cell. So when the T cells are intact, there is always positive Candida intradermal injection. Candida intradermal test is always positive, which shows that the T cells are intact or working properly. Then we have hyper IgA syndrome. Hyper IgA syndrome, its pathophysiology is unknown, and it is the most common primary, the word primary immunodeficiency, and it is A. So there is atopic dermatitis or atopic asthma. Their majority is asymptomatic. asymptomatic. They have increased rate of autoimmune disorders. A for asymptomatic atopia, autoimmune disorders. Then we have anaphylaxis whenever they are transfused with blood in case of ER. So anaphylaxis to IgA products including packed transfused blood, and there is always increase IgA as the name shows, but normal IgG and IgM, they have increased susceptibility to giardiasis. Next we have common variable immunodeficiency. It is a defect of B cell differentiation. B cell differentiate into plasma cells and immunoglobulins. So when B cell cannot differentiate into the further successive generation, there is plasma cell decrease and there is decreased immunoglobulins such as IgE, IgA, IgE. So decreased plasma cells, so no immunity, no passive immunity, and decreased immunoglobulin cannot cope with infection. So there is recurrent infections. Same, the infections are please shine my skis, and also this is the pathophysiology presentation. Having an intact thymus, and they are asymptomatic in infancy, but diagnosed post puberty. So they have increased risk of sinopulmonary infection. As we know, they have increased risk of infection which lead to COPD, which leads to bronchiectasis. Also increase the risk of autoimmune disorders and lymphomas. In the GIT, whenever they are infected, the GIT, we have nodular lymphoid hyperplasia. So this is all about the B cells disorder. Next we will discuss T cell disorders, combined T and B cell disorders.